Very good afternoon and a warm welcome to this virtual monthly meeting of AOGD. This is the first meeting after Team MAMC has taken over AOGD from Safdarjung Hospital and led by Dr. Rachla. The medical fraternity, especially the OBGYN fraternity, is shaken by the events led to suicide of Dr. Archana Sharma. This is a serious issue requiring multi-pronged approach. And apart from participating in the local emergency response team, AOGD proposes to form an advisory or a support group to help its members in management of adverse events. Dr. Vijay Juchi has agreed to lead this cell, and I would request all members to send us their suggestions so that we can decide how it can effectively help us in further avoiding such situations. I welcome Team Lady Harding led by Dr. Reena Yadav to conduct today's clinical meeting, and also welcome the judges for today's meeting, and Dr. Amita Jain, Dr. Rajesh Kumari, Dr. Shruti Bhatia, and Dr. Vijay Juchi. I now invite Dr. Deepti Goswami to present the Secretary's report.
Thank you, Madam. It's my pleasure to present my first report as Secretary AOGD for the year 2022-23. I would like to thank our academic partners for these clinical meetings, MQ Pharmaceutical Limited. I would begin at a happy note by congratulating all our AOGD members who have won laurels at the AICOG conference held in Indore. And I will just briefly take their names. Awardees for 2021 are Dr. Pratima Mittal, Dr. Alpana Singh, Dr. Neeja Goyal, Dr. Mala Arora, Dr. Monica Gupta, Dr. JB Sharma, Dr. Abha Singh, Dr. K. Aparna Sharma, Dr. Manisha Kumar, Dr. Nilanchali Singh, Dr. Divya Pandey, Dr. Arshna Kumari, Dr. Surya Malik. And these are the awardees for the previous years, 2020, Dr. Kiran Guleria, Dr. Nutan Agarwal, Dr. Chanchal Singh, Dr. Taru Gupta, Dr. Mala Arora, Dr. Monica Gupta, Dr. Divya Pandey, Dr. Ankita Jain, Dr. Chingbaiklun Chaute, Dr. Sonal Bhatla, Dr. Avantika Gupta, Dr. Vidhi Chaudhary, and Dr. Penzi Goel. The AOGD clinical meeting, monthly meeting was held at VMMC and Safdarjung Hospital on 1st of April 2022. The team Safdarjung presented 4 very interesting cases from Obs-Gynae repertoire, and they generated much academic discussion. On the same day, a general body meeting of the AOGD was held, and the Secretariat was moved from Safdarjung Hospital to our department, that is Department of Obs-Gynae, Maulana Azad Medical College. Here I share some of the glimpses from the event, where both the teams can be seen in these photographs. Among the past events, we had a string of activities by various subcommittees. So this was a workshop on breast and cervical cancer screening, which was attended by more than 200 nursing students, teachers, and others. And these are the pics from this screening. Next was the event held by Rural Health Subcommittee, which was a webinar. This was held along with the Indian Academy of Pediatrics. This was a webinar on transition and adolescence. Then there was a PG forum, the topic of which was hypertensive disorders in pregnancies, and it was well attended by postgraduate students from all over Delhi. Then the public forum was held on 21st and 22nd April, and you can see a good public participation in this program of 2-day event. A webinar was held by the Oncology Subcommittee entitled Towards Elimination of Cervical Cancer, Translating Guidelines to Practice. A Safe Motherhood Committee held a webinar on induction of labor, optimizing outcomes just a few days back. We have a string of forthcoming events lined up. On 5th of May, there is going to be an event by Genetics and Fetal Medicine Subcommittee on management of CNS anomalies. 13th May, there will be CME by Endometriosis Subcommittee. 16th May, there will be PG Forum on gestational trophoblastic disease. On 19th May, there will be a event held, being organized by ESI Hospital along with the Adolescent Subcommittee, Prevent, Promote, Protect Adolescent Health. 21st May, there will be Oncology Subcommittee event, Elimination of Cervical Cancer. 26th May, CME by the Endoscopy Subcommittee. 31st May, CME on Ethics and Communication by the Multidisciplinary Subcommittee. And then next AOGD monthly clinic meeting will be held at Indraprastha Apollo Hospital on 27th of May 2022. And a major announcement is for an offline academic event, which will be a FOGSI conference being organized in collaboration with the AOGD and Delhi Gynecological Forum. This is going to be on 11 June 2022. And the theme of conference is going to be Obstetrics and Gynecology, Charting Difficult Territories. More information we will put on the groups as the program material is getting materialized. And now the major announcement, this year's annual AOGD conference will be held on 12th and 13th November 2022. It will be an offline event. As of now, we are planning, and we urge all the AOGD members to block the dates and attend this event in huge number. After 2 years of pandemic, we look forward to meeting and discussing many, many things. And this, for information, is the AOGD contact details, our email ID, WhatsApp group, and our office bearers numbers and contacts. Thank you. Now I call upon Dr. Reena Yadav, who is going to start the clinical meeting proceedings. Dr. Reena Yadav, please.
Good evening, everybody, and a very welcome from Lady Harding. We have 4 presentations, and first presentation will 3 are interesting case reports and 1 is paper presentation. First is by myself and Dr. Kanika, and I'm going to share the screen.
Good evening, everyone. I am Dr. Kanika, and I'll be presenting a rare ovarian cancer variant, onerous diagnosis and management. I'll be presenting the case report, and the discussion will be followed by Dr. Reena ma'am. Is my screen visible? So our patient was a 48-year-old postmenopausal patient. She was postmenopausal for 2 years and she was para 6 live 4. She presented to us with complaints of postmenopausal bleeding for 9 months, pain, abdomen and constipation for 6 months. She had undergone laparotomy 3 months prior to presenting to us, and she presented there with a similar diagnosis of pain, abdomen and constipation and postmenopausal bleeding. And there the doctors were unable to do anything owing to dense adhesions as mentioned in the notes provided, and abdomen was closed. On examination findings, on per abdominal, a midline vertical scar was present. A 30 into 20 centimeter mass was appreciated, and it was corresponding to a 32-week size gravid uterus. It was an irregular hard fixed tender mass with no free fluid palpable. In per speculum examination, cervix was pulled up. In per vaginal examination, cervix was pulled up and deviated to the right side, and a hard mass was felt through the left fornix, and it was fixed. In per rectal examination, similar mass was felt with parametrium and rectal mucosa free. In her investigations, her ovarian markers were CA125 being 31 international units per liter, CEA being 1.13 nanograms per ml, and CA19.9 being 17 units per ml. All were within normal range. LDH was 200 international units per liter. Rest investigations were within normal limits, with chest X-ray being normal. Investigations in the further investigations, we got an MRI abdomen and pelvis for the patient, and it revealed a large, well-circumscribed, lobulated abdominopelvic mass lesion measuring approximately 10.2 into 12.7 into 14.2 centimeters, and the inferior extension of that particular mass was up till the left adnexa, and this was displacing the uterus anteriorly and to the right. The mass showed heterogeneous signal changes with multiple areas of cystic degeneration and necrosis, as can be appreciated in the image marked by brown arrows. The lesion was abutting the posterior wall of the uterus, displacing the bowel loops. Another similar lesion of 3.1 into 2.2 into 2.1 centimeter was present in the right adnexa. Bilateral ovaries were not visualized separately. There was no significant lymphadenopathy in pelvic and para-aortic lesion, and no free fluid was there. So the probable diagnosis of a query large subserosal fibroid with possible sarcomatous transformation was made, or there was a query malignant ovarian tumor. So a decision of explorative laparotomy was taken after optimizing the patient. The per-operative findings were as follows. So there was a large mass of approximately 30 into 25 centimeter, which can be appreciated in the image marked by a green arrow, and this was adhered densely to a sigmoid colon marked by the brown arrow, and this was adhered densely retroperitoneally as well. Dense adhesions of this mass with large bowel loops and omentum was also present. Uterus appeared bulky and densely adherent to the above mentioned mass and also to the left tubo-ovarian mass, which was of around 6 into 6 centimeters dimensions. There were no gross omental deposits seen. So the procedure done was total abdominal hysterectomy with bilateral salpingo-oophorectomy, with omentectomy, with abdominopelvic mass and sigmoid resection, followed by re-anastomosis and divergent ileostomy with pelvic lymphadenopathy and para-aortic node sampling. The sample received, the specimen retrieved was sent for histopathology, and it revealed that the sections from the mass, which was query labeled as left ovary bias, showed features of high-grade neuroendocrine carcinoma, showing many areas of necrosis and hemorrhage with infiltration into the sigmoid colon, which was seen densely adherent in the previous picture. And this was this particular infiltration was up till the serosa, reaching till muscularis propria. Sections from the colonic wall along with the pericolonic fat were free from the tumor. Sections from the right ovary were also consistent with high-grade neuroendocrine carcinoma. Lymphovascular invasion was seen into the colonic submucosa and also in the ovary, with the mitotic figures being 6 to 8 per hypa field. Resected cut ends of the sigmoid colon were free from tumor. Sections from endometrium had progestin effect. Sections from cervix, myometrium, right and left parametrium were unremarkable. Sections from the pelvic peritoneum showed areas of hemorrhage, necrosis, and tumor deposits. Omentum, pelvic, and para-aortic lymph nodes were free from tumor. Immunohistochemistry analysis showed strongly positive for BCL2, CD56, neuron-specific enolase, progesterone receptors, and P53. And it was negative for various labeled IHC markers, most important being CK7 and CK20. So the final stage of the tumor was labeled as FIGO stage 4B. The patient was referred to higher center in consultation with medical oncologist.
We consulted our radio oncologist, and he advised her to send the patient to higher center. And there, in consultation with medical and oncologist, patient was started on tablet etoposide 50 milligram once daily for 2 weeks on and off regimen. On follow-up after 4 months, when the CCT was done, there it was found that the tumor has metastasized to almost everywhere, lungs and liver and lymph nodes, and everything was involved. And as you can see in this particular MRI picture, at same particular place where the tumor was removed, it has relapsed over that area. And this, unfortunately, this lady succumbed to her illness within 6 months after primary surgery. When we reviewed the literature, why we are presenting this particular case? Because of the rarity of this particular entity, as well as the treatment protocol, no standard treatment protocol or guideline exists. What exactly is this tumor? Neuroendocrine neoplasma, rare tumor entity arising from diffuse neuroendocrine cell system. Most neuroendocrine neoplasia are located in the gastroenteropancreatic system or lungs. And as far as the ovary neuroendocrine tumors are concerned, they are very rare. Primary, and their various varieties are primary or metastatic carcinoid tumor, small cell carcinoma of pulmonary or hypercalcemic type. The one which was there in our patient was large cell carcinoma, and which is very, very rare. Otherwise, it has been seen that this kind of neuroendocrine tumor may be associated with epithelial tumors or germ cell tumor, teratomas or stromal tumors, or they can arise with for the neuroendocrine differentiation of these particular varieties. So we have, on reviewing various case reports, it was found that primary pure large cell neuroendocrine carcinoma of the ovary is a rare primary malignant tumor of the ovary. And it was recently included in the latest WHO or classification also. And this tumor is supposed to be a high-grade carcinoma with aggressive behavior and poor prognosis. So various case reports which have published have shown most of the time it is associated with epithelial tumors or other tumors. And there are very few reports which are pure large cell neuroendocrine tumor of the ovary. As far as the presentation and diagnosis in various case reports which we have evaluated, the clinical presentation is similar to epithelial ovarian cancer, such as presence of ovarian mass or pain distension. The diagnosis is difficult to made by clinical, radiological, or by any other specific markers. And microscopic pictures are mostly solid and cystic components, and they are arranged in sheets and cords. And necrosis is one of the feature which is always present in this particular type of tumor, which differentiate it from the primary carcinoid tumor. And confirmation is always by immunohistochemistry. At least 2 markers should be positive. As you can see in our case, there were 2 markers, that is CD656 and neuron-specific enolase. These 2 were positive in our case. And CK7 and CK20 were negative. It means it was not of epithelial origin. So it goes in favor of that this is a pure neuroendocrine tumor. As far as the treatment protocol, which we have evaluated in different case reports and review of literature, because of the rarity of this particular entity, only limited data to guide the treatment of patients with high-grade neuroendocrine carcinoma exist. And most patients undergo primary surgery to obtain tissue diagnosis and staging and tumor debulking operation. Various combination of chemotherapy have been tried with variable results. These are the various cases which with pure large cell endometrial carcinoma. As you can say, the age of the patient varies from 27 years to 75 years. Most of the time these tumor occurs in young patients, but when we evaluated various reports, the age varies from 27 to 75 years. And the chemotherapy, and as you can see, most of them are diagnosed in higher stages, stage 3 or stage 4, except 1 or 2 cases where 2B it was diagnosed. And even if we diagnose in early stages, prognosis for this particular disease is very poor. Different chemotherapy has been suggested, especially platinum-based chemotherapy in combination with etoposide. And as far as the overall survival in various reports are concerned, it has been seen as low as 45 days to as up to 64 months. So it's a tumor with a very poor prognosis and aggressive behavior. So to conclude, to primary pure high-grade neuroendocrine carcinoma of is unusual. It's very rare, and it's defined by extremely malignant behavior, malignant tumor. Early diagnosis is difficult. Treatment guidelines still evolving. It is known, however, that the surgery is the cornerstone of therapy, and it should be performed in any case. Even at early stage, prognosis is poor, and tumor has an aggressive lethal outcome. Maybe more studies are warranted to put some more light on this particular rare tumor and to optimize treatment. These are the references. Thank you so much for patience hearing. Thank you. Now Dr. Swati will present her paper.
Thank you, ma'am. A very good evening to the respected August members of the audience present today. It is my proud privilege to be presenting this study in front of you today. I'm Dr. Swati. I'm a professor in the Department of Obs and Gynae. And today I'll be presenting a study which was conducted as a thesis in the department by our student, Dr. Shalini Singh, and I was a guide. So the topic of my presentation today is cervical cancer screening in HIV seropositive women. Is pap smear enough? How do we change?
Swati, please share your screen.
Okay, it's paused. I'll just share it again, ma'am. It was paused. Is it visible now, ma'am?
Yeah, we can see it now.
Thank you so much. So I'll be talking about cervical cancer screening in HIV seropositive women. Is pap smear enough? How do we move this, Kanika? It's not moving. It's not moving. Okay. Okay. So as we all know, Cervical cancer is one of the leading cause of cancer-related mortality in India. And the most important risk factor is chronic persisting human papillomavirus infection. And as we all know that the risk factors for HPV and HIV infection are pretty same, and HIV women being immunocompromised have not only the higher risk of acquiring HPV infection, but have a higher rate of progression of this infection into a precancerous and a cancerous lesion. Expectedly so, the prevalence of pre-invasive lesions of the cervix in these women ranges from 8.7% to as high as 69%. And although pap test is the recommended screening method, even in high-risk women, it has concerns in HIV-infected women owing to high false negative cytology reports, especially higher incidence in HIV-positive women to the tune of 14 to 26%. And of course, a higher attrition rate, which is found in our population. HPV testing has been shown to be highly sensitive, but unfortunately, it's not accessible to most of the population in our nation due to its high cost and requirement of standardized laboratory infrastructure. Colposcopy here comes into play. It has a high sensitivity and specificity, and it is easily available in most of the government, good tertiary level government setups. So it may be the preferred screening tool in countries with limited resources. So this study was conducted in a department with the aim to compare pap test, which was done by liquid-based cytology, and colposcopy-derived sweet score for the detection of pre-invasive lesions of the cervix in HIV seropositive women. It was a cross-sectional study which was conducted between November 2019 to September 2021 in the Department of Obs and Gynae. And we recruited HIV seropositive women from the ART Center of LHMC and Kalavati Saran Children Hospital. We calculated the sample size from this very complicated formula, but basically it took into consideration the sensitivity of colposcopy in HIV seropositive women, as well as the sensitivity of pap test in these women. And taking an alpha error as 0.05 and beta error as 0.02, the sample size was calculated to be 81. But to increase the accuracy and the relevance of the study, we took 40% more women, and we took a total sample size of 120 women. Our inclusion criteria were, we took all non-pregnant HIV seropositive women in the age group of 25 to 50 years, and we excluded those women with diagnosed carcinoma cervix or pre-invasive lesion in the past. Women who were using any immunosuppressive therapy, which would increase the risk of cancer in these patients, were also excluded from the study. Now, this is a flow chart depicting how the study was conducted. So we recruited these 120 women after informed consent, and then a detailed history and examination was carried out. And in the same sitting, a pap test and a colposcopy was done for these women. The colpo result obviously was obtained then and there, and if the sweet score was less than 5, we told them to follow up with a pap report after 2 weeks. However, if the sweet score was 5 or more, we took a biopsy on the same sitting after informed consent, and fortunately for us, all the women did consent for getting the biopsy taken, and they were then called with the biopsy and the PAPS report after 2 weeks. After 2 weeks, when the women came with the pap test result, and if the result was negative, they were just told to have a routine follow-up. Whereas if previously the colposcopy was normal and biopsy had not been taken, and this time the pap result has come positive, that is more LCL or more, then a biopsy was done, if not done before. And fortunately for us, we did not have any such patients also where the colposcopy was normal and the paps was abnormal. So these were the results. Out of the 120 HIV seropositive women screened, we found abnormal colposcopy to be there in 22 women, that is 18% of women, and biopsy was taken in all. When we look at the distribution of PAPS test findings, we see that PAPS was normal in 114 out of 120 women, that is 95%. Although this
Hello.
Am I
Yes, ma'am.
audible now?
Yes,
Yeah.
you are, Swati. Carry on.
Yeah, thank you. Yeah. So when we look at the PAP test findings, we see that the PAP test was negative in 114 out of 120 women. That is 95% of the women, and was abnormal in 6 out of 120 women. That is 5%, in which 2 had ascus, 3 had LCIL, and 1 had squamous cell carcinoma. Next, please. Next slide, Shiva. Shivam, can you please put the next slide? Yeah. So none of the women who had a normal sweet score had any abnormality on the PAP test detected. Next, please. But when we look at the women who had an abnormal colposcopy, that is a sweet score of 5 or more, that is 22 women who had an abnormal colposcopy, PAPS was found positive in only 6 of these women, and it was found negative in 16 women. In the 6 women who had a positive PAPS as well as a positive colposcopy, biopsy was positive in all the 6 women. However, the women in which the 16 women who had a PAPS negative but had a colpo positive had biopsy positive in 6 out of these 16 women, and the biopsy was negative in 10 out of these women. Next, please. So, in total, there were 12 out of 120 women who came out positive for pre-invasive or invasive lesions of the cervix after the biopsy. Out of this, 5 were CIN1, out of which 4 were missed by PAPS. 2 were CIN2, out of which 1 was missed by PAPS. 3 were CIN3, out of which 1 was missed by PAPS. And there were 2 cases of invasive cervical cancer, out of which none was missed by PAPS. 1 was reported as HSIL on PAPS and 1 was reported as squamous cell carcinoma on PAPS. Next, please. So the inference that we draw is that 50% of the women with pre-invasive lesions of the cervix, that is 6 out of 12 women, would have been missed on screening if colposcopy was not done in them at their first visit. When we look at the statistical relevance of this, and we calculate a kappa coefficient for this, we see that the kappa coefficient was 0.37, which shows a weak agreement between the colposcopy and the PAP test, suggesting that colposcopy is a better tool in screening in this population. Next, please. The limitation, however, the study was not without limitations. Our sample size was small, so that we cannot generalize these findings to the larger population. Also, in order to calculate the exact sensitivity, specificity, predictive value of colposcopy as well as pap smear, we needed to do a biopsy, which is the gold standard in all patients, but we could not do it because of ethical concerns. So we could not calculate the sensitivity and the specificity of these tests in this population. Next, please. When we look at the available evidence, we see that in a recent review of 81 patients who were treated with cervical cancer, it was found that 87% of the women with stage 1 cancer cervix and 13% with stage 2 cancer cervix previously had normal pap smear on regular cancer cervix screening, suggesting that pap smear alone is not enough. In another similar study to ours, Anderson and colleagues also found out that pre-invasive lesions of the cervix were missed by pap test in 14% of HIV positive women, which was picked up subsequently by colposcopy. Next, please. Now, what was the need for such studies? Such studies are needed because still the guidelines do not have a consensus as to what should be the ideal screening method in these HIV positive women. Different bodies give different opinions, but yes, all are of this one common opinion that these women are vulnerable, they're at high risk, and they need screening with either better tools or they need more frequent screening. Like the NACO says that an annual pap smear should be conducted in these women. The US Preventive Task Force recommendations are more frequent screening, but they don't specify the frequency of screening. The WHO in 2021 has come up with the guidelines which recommend primary HPV DNA testing to be the preferable mode of cervical cancer screening. And in HIV positive women, this screening should start at 25 years of age as opposed to 30 years of age in normal population. And also the screening frequency should be preferably 3 years as compared to 5 years in the general population. The CDC guidelines released in 2021 also suggest that annual pap test should be done between 21 to 29 years and co-testing subsequently after 30 years, but again, that at an increased frequency of 3 yearly. They also say that the screening should not be stopped at 65 years as is done for the normal population, and the screening should continue beyond 65 years for these women because they are more at high risk to develop these precancerous and cancerous lesions of the cervix. Similarly, they support induction of HPV 16 and 18 genotyping in the initial screening protocol wherever the facilities exist. It is the British HIV Association, that is the BIVA guidelines in 2019, which say that again recommend screening with pap test because of its ease and feasibility, but they also advocate an initial colposcopy at the onset of HIV diagnosis wherever the resources permit. Next, please. So considering the conditions in our country and considering the drawbacks that we have, the attrition rates that we have, few things are very, very important for us to understand is that these HIV seropositive women are a very vulnerable group of women who are at very high risk for developing cervical cancer, and they need effective screening protocols. And so in a country like ours and with a setup like ours, colposcopy should be used for routine initial screening test in combination with pap test in these high-risk women to improve the detection rate of pre-invasive lesions of the cervix and to prevent any missing out on these lesions, because use of only pap test as the sole screening modality definitely may miss out these lesions in the precancerous and treatable stage. So next, please. These are few references, and I thank you all for a very patient hearing, and I hope you found this presentation useful. Now, for the next presentation, we have Dr. Deepika with us, who is an associate professor in our department and who will be presenting her study. Thank you so much.
Mr. Shivam, please unshare your screen.
Done, ma'am. You can share now.
Good evening, respected seniors and the colleague. I'm Dr. Deepika, and we are presenting a case of the bladder diverticula mimicking as a hematocolpus. My patient was Mrs. A, 24 years old lady, housewife, resident of Kanpur. She was admitted in our hospital on 31st March 2022 with the chief complaint of amenorrhea last for 1 year following a laparotomy done in the Kanpur for some anomaly of the genital tract. On menstrual history, she achieved menarche at 18 years of age, and as per the history given by her, cycles were off and on with the scanty flow. There was only a spotting which lasting for only 1 day. For this, she doesn't require any pad. History of the pain lower abdomen off and on present. There was no history of the cyclic pain abdomen, lump abdomen, and no history of the fever or cough suggestive of tuberculosis, and there was no any urinary and bowel problems. She was married 1.5 years back, and she was consulted a gynecologist for this. Was advised MRI. She in a private hospital in February 2020 1 year back for the query hematocolpus. On laparotomy, the couple was told that there was no uterus and they sent back her. Patient complained of the amenorrhea ever since and was referred to the Delhi. Although the dyspareunia had improved over the time. Just a second. In the past, there was no history of any medical illness. She was married for 1.5 years, nullipera. In the family, she was the first born to the non-consanguineous marriage, and there was no history of the similar illness in the family. On examination, her BMI was 19 kg per meter square, and the breast development was the Tanner stage 4. Vitals were stable and within normal limit. On per abdomen examination, abdomen was soft. There was a fenestrial scar, no organomegaly. On local examination, pubic hair development was the Tanner stage 4, and no abnormality detected in the external genitalia, labia minora, and the majora. On per speculum examination, there was a normal vagina of around 4 to 5 centimeter length, but the cervical opening was not seen. On per vaginal examination, there was an ill-defined cystic mass around 8 into 6 centimeter, which felt just above the vagina. On per rectal examination, same mass felt about 5 to 6 centimeter from the anal opening. And on PVR examination, the mass was just above the upper end of the vagina. On investigations, routine CBC, LFT, KFT, and the hormonal profiles were within normal limit. There was no abnormality detected in the urine routine microscopy. Urine was sterile in cultures. On ultrasound, uterus enlarged in size with the cystic collection, query hematometra, and there was a bilateral ovaries, normal. In the MRI films, as we can see, there is a grossly distended vagina, that is hematocolpus, with the hypointense foci inside, which are the echogenic on the ultrasound, suggestive of blood clots, but the normal configuration of uterus is not visualized. In this picture, we can see both the rudimentary horn. This one the right side rudimentary horn. This is the left side rudimentary horn. In the second picture, this is the right side of the ovary, and this is the left side of the ovary. So the possibility was the MRK syndrome with the hematocolpus. But there are a few points against this diagnosis. There was absence of the cyclic pain abdomen, absence of any evidence of the hematosalpinx or the endometriosis, and inability to identify the uterus well. So we did the diagnostic laparoscopy followed by the laparotomy in the same sitting. On diagnostic laparoscopy, there was a known functional rudimentary horn seen on the both sides with a band in between the two, and additions present between the bowel, left rudimentary horn, and the left fallopian tube. And there was a 5 to 6 centimeter bulge seen between the bladder anteriorly and the band posteriorly. In the first picture, it is the right side of the rudimentary horn. In the second picture, it is the left side rudimentary horn, and this is a band which connect the both rudimentary horns. And anterior to this band, there was a cystic bulge. On laparotomy, bilateral tubes and ovaries normal, rudimentary horn around 2 to 3 centimeter long, seen on the both sides with the fibrous band in between. And there was a thick wall cyst of around 5 centimeters seen anterior to the rudimentary horn band and the posterior to the bladder. In the first picture, this is the right side of the rudimentary horn, and this is a band between both rudimentary horn, and anterior to this band, there was a cyst which is slightly deep in situation. And this is the left side of the rudimentary horn, left side tube, and the left side of the ovary. Intra-op cystoscopy was done, in which there was no defect in the bladder wall. So we did the cystectomy. Cyst contained was the clear fluid initially, followed by the turbid fluid on the base with the 39 stones. Largest was 2 centimeter. After the cystectomy, bladder was retrogradely filled, and at that time we found a very small query rent around 5 mm in the posterior inferior bladder wall, which was repaired. Cystic fluid cytology showed the mature squamous cells only, and cystic fluid biochemistry, there was a protein 0.1 gram %, and the creatinine was 55 milligram %. So we sent the urine for the creatinine, which came out as a 60 milligram %, almost similar to the cystic fluid. On histopathologic examination, cysts were lined by the creatinizing stratified squamous epithelium. Underlying submucosa shows the chronic inflammatory infiltrates, and the below submucosa, there was a thickened muscle layer which appeared unremarkable. So the impression was the squamous epithelial type cyst. abdominal drain removed on day 5, and the patient discharged on day 6, and the catheter removed on day 21, and patient now doing well. In the follow-up, we advise the patient pregnancy by the surrogacy. So the possibilities are MRK syndrome with the cyst in this particular position. It might be arise from the Mullerian duct or from the remnants of the Wolffian ducts, or from the any structure which arises or derived from the urogenital sinus. First differential diagnosis for the Mullerian cyst, but it can't. This cyst can't be the Mullerian cyst because the Mullerian cyst lined by the columnar or the cuboidal epithelium. Second differential diagnosis for the Gardner cyst because of the second diagnosis was the Gardner cyst because of the position of the cyst, but the Gardner cyst again lined by the cuboidal or the low columnar epithelium. Third differential diagnosis was the paraurethral cyst, which is the skinny gland cyst. Skinny glands are derived from the urogenital sinus, and the stones are well reported in the skinny gland cyst. And it is also lined by the stratified squamous epithelium, but the skinny cyst are situated on the base of the urethra. So the position of this is not in favor of our patient, our case. Fourth differential diagnosis was the bladder epidermoid cyst, although it is very rare, but it is lined by the stratified non-keratinizing squamous epithelium, and the muscle layers are absent in the bladder epidermoid cyst. And the fifth differential diagnosis was the bladder diverticulum. It may be congenital or acquired. Bladder diverticulum contains the urine and the muscular layer are also present. Usually it is lined by the transitional epithelium, but the keratinizing stratified squamous epithelium metaplasia is well reported. So in our case was the MRK syndrome with a cyst which situated in the near to the bladder, just posterior to the bladder, and contents of the cyst was the multiple stones and the biochemically urine-like fluid. With the epithelium lining was the keratinizing stratified squamous epithelium with the muscle layer, which make a diagnosis of the bladder diverticulum with the stones. In MRK, 1 in 4,500 female. Majority of the cases, it is sporadic, but it can be an autosomal inheritance. There are two types of the MRK syndrome. Type 1 is the isolated and the less frequent, and the type 2 associated with the other systems abnormalities. Reported urinary anomalies with the MRK syndromes are upper urinary tract malformations, which is present in around 40% of the cases. They are the unilateral renal agenesis, ectopia of one or both kidney, renal hypoplasia, horseshoe kidneys, or the hydronephrosis. On review of the literature, not even a single case reported for the MRK syndrome with the bladder diverticulum. Bladder diverticulum is an outward bulge of the inner lining of the urinary bladder through a defect in its muscle layer. It may be the congenital or acquired. Congenital bladder diverticulum results from the hypoplasia of the muscular layer of the bladder wall. Diverticulum may be true and false. In the false diverticulum, there was only a submucosa and the mucosa layer, but the true diverticulum contained the all layers of the bladder, which include the mucosa, submucosa, and the muscle layer. Clinical features of the diverticulums are lower abdominal fullness, discomfort, stone in the bladder diverticulum due to the urine stasis, as in our case it was present, difficulty passing urine, hematuria, pain and fever due to the diverticulitis, urine flowing backward into kidneys. In 30% cases, it may be asymptomatic. Keratinizing stratified squamous epithelium metaplasia due to the persistent mucosal inflammation can be present. Bladder diverticulum can be diagnosed by the intraluminal examination by the cystourethroskopy or the diverticular contrast inspection. Treatment is the diverticulectomy. On review of the literature, as I said, there was not a single case reported as a MRK syndrome with the bladder diverticulum, although there are few studies which include the bladder diverticulum in the male and female both. As we can see, bladder diverticulum is a very less common in the females compared to the males. And in these studies, they mainly aim of the study was the analysis of the histopathological variations in the bladder diverticulum. Most common histopathological changes are the chronic inflammations and the metaplasia. And the most common metaplasia was the squamous metaplasia, which may be the keratinizing and non-keratinizing. Out of them, in a one study, 7 out of 74 cases, 7 cases reported the stones. There is only a single reported study on the vesical diverticulum in the urinary bladder of the female. In this study, they include the 26 cases of the female bladder diverticulum, age range between 9 to 79 years, and the clinical presentation was the features of the recurrent urinary tract infection with the lower abdomen discomfort. Out of 26 patients, 8 patients had complications. Out of 8, 7 in the 7 there was the upper urinary tract abnormalities, and only in a single case, 1 patient reported as a vesical calculi. So the key message: the occurrence of the vesical diverticulum in the female patient is normal, and the vesical calculi in the female rarely seen in compared to the male patient with the diverticula. Most congenital bladder diverticulas are single and asymptomatic and managed conservatively. In symptomatic cases, required surgical intervention. Stone removal followed by the diverticulectomy or the marsupialization is one of the options for the management. And the take-home message is: when the clinical details and the investigations do not corroborate with each other, we should be prepared for the atypical diagnosis. The patient and the family should be informed well of the same, and a broad consent should be taken in such cases. Thank you. Now I request to the PM to present the next case.
Is my screen visible?
Yes, ma'am.
Okay. So Dr. Shweta, who is a senior resident in the Department of Obs and Gynae, will be presenting a rare cause of recurrent UTI. Dr. Shweta, please start. Shweta, are you there? Dr. Shweta?
Hello, good afternoon, ma'am.
Yeah, please start, Dr. Shweta.
Ma'am, my patient Mrs. S is 46 years old female who is a resident of Faridabad, presented to Gynae OPD with chief complaints of pain in lower abdomen and burning micturition with fever off and on for last 1 year. There was no history of hematuria or passage of stones. In menstrual history, she was menopausal since 1 year. In obstetric history, she was para-4, live-4, A1, and all were full-term normal vaginal delivery. Her last childbirth was 10 years back, after which copper T was inserted. Patient fed the thread during first 1 year, after which no thread was fed. On consulting a local practitioner, she was counseled that IUCD had expelled spontaneously. However, patient conceived 3 years later, but had spontaneous bleeding for which dilatation and evacuation was performed. In treatment history, for repeated urinary complaints, she was prescribed multiple courses of antibiotics. A misplaced IUCD was detected on X-ray pelvis in a local facility for which she was referred to LHMC. This is an X-ray pelvis film showing IUCD, inverted IUCD, just above the pubic symphysis. Her past and family history was not significant. Systemic and pelvic examination was normal, and all her routine investigations were normal. Next slide, please. At LHMC, the transvaginal ultrasound was done. First picture shows empty endometrial cavity, and the next picture shows a focal echogenic lesion along posterior aspect of urinary bladder. A 3D ultrasound was performed later on, which showed IUCD with mild granulation tissue inside the urinary bladder. A urology consult was sought and CECT pelvis was advised. This is a sagittal film section of CECT pelvis showing linear hyperdense object within the urinary bladder. After these investigations, a plan of cystoscopic removal of misplaced intravesical IUCD was performed. This is a cystoscopic picture showing intravesical IUCD with incrustations over its horizontal limb and coiled thread. Inflamed bladder mucosa was seen, and rest of the cystoscopic findings were normal. This is a small video showing cystoscopic removal of misplaced IUCD.
Shubham, the video is not working. Shubham, can you help? The video is not working. What should I do? It is a very nice video anyway, in which we observed that there were pus plates, encrustations over the horizontal limbs of IUCD, and on putting pressure, this IUCD was moving freely. After introducing a cystoscope, we could take out the IUCD from the urethra. This is the IUCD with encrustations over the horizontal limb, and it has been compared to a normal IUCD. So how do perforations occur while inserting the IUCD? So most commonly, the primary perforation occurs at the time of insertion. It is related to mostly the timing of insertion. The postpartum uterus, recent abortion, mid-trimester abortions, or in the setting of sepsis, the uterus is very soft and it is very pliable. It is difficult to feel the resistance. And if the experience is, if the provider is inexperienced, then a perforation can occur at that time. Another thing is faulty technique of insertion. Instead of withdrawing, if you are pushing, then also perforation can occur. Another, a very important factor is undetected extreme anteversion or retroversion. If we are inserting IUCD in acutely anteverted uterus, there are chances of posterior perforation in the POD, whereas in an acutely retroverted uterus, the chances of anterior perforation in the utrovesical pouch are present. The other problems which could be encountered are deformed anatomy of the cervix or uterus. More often primary perforation occurs, but secondary perforation can also occur later on due to chronic inflammation, which leads to erosion of the uterine wall, and it is more commonly seen in patients who are having a previous cesarean or have undergone a DNE. So the complications related to IUCD perforation are, the IUCD most commonly is dislocated in the lower uterine segment, as we have seen in our practice, or in the cervical canal. But it may be having a partial perforation in the myometrium. In this condition, we can easily remove it by hysteroscopy. It may also be embedded totally in the myometrium, in which case we'll not be able to see it through hysteroscope or through laparoscope. It may also be going through all the three layers, the endometrium, myometrium, and perforating through the serosa layer, and partially it may be coming out. And when all the copper-T comes out and falls in the peritoneal cavity, then it is known as complete perforation. Most often it occurs in the POD and it is engulfed by omentum, but sometimes migration, transmigration of copper-T may occur, and it may perforate into adnexa, colon, bladder, appendix, stomach, liver, right iliac fossa, and even anterior abdominal wall. So the risk of IUCD perforation is 1 in 1,000 cases. Until now, about 70 cases of IUCD I could find in the literature. Adhesion or migration can lead to chronic pain, urinary symptoms, menuria. Menuria is that during periods, the patient will have bleeding in the urine. Hydronephrosis, bladder stone formation, intestinal obstruction, peritonitis, fistula formation, hemorrhage, and infertility. So WHO advocates removal of misplaced or malpositioned IUCD due to risk of injury to the adjoining organs and subsequent complication, only even if the patient is asymptomatic. So now comes the problem of diagnosing misplaced IUCD. The most commonly and the investigation of choice is 2D ultrasound by transvaginal route. It is widely available. We are doing it every day. It is inexpensive and there is no radiation exposure. In addition, it can find out the IUCD position, any displacement, or myometrial perforation. 3D ultrasound is becoming the standard practice of routine evaluation of IUCD because we can appreciate finer details like the extent of perforation or migration. In case we do not find the IUCD in the uterus on ultrasound, then we can get an X-ray abdomen and pelvis done, both AP and lateral views for extra-uterine IUCD. Then we can be sure whether IUCD has been expelled or it is still present in some other part of the abdomen or pelvis. CT, however, is the best modality for evaluating complications like distal perforation, abscess formation, and bowel obstruction. MRI is not very useful. So removal of IUCD will be based on where it is present, patient's condition, availability of equipment, and surgical expertise. In the literature, I could find that in cases of IUCD in the bladder, many procedures have been tried. Cystotomy, oleum laser lithotripsy followed by cystoscopic IUCD removal, open vesicolithotomy, or cystoscopy. There are two unique cases in which the IUCD migrated in the retroperitoneal space and led to fibrosis around the right pelvic ureter, which led to obstruction and formation of right hydronephrosis. In this case, they had to do a laparotomy because they could not approach the ureter because of the stricture. And then they did removal of the stricture and IUCD. And after that, ureteric reimplantation and bladder repair was done. This is a very interesting case. In this, we can see that the IUCD is seen in the bladder lumen and traversing the bladder wall. And in the intra-op picture, we can see partially the IUCD is protruding out. So they tried to attempt cystoscopy, but it failed. So they had to resort to laparotomy, and then bladder repair was done. This is another very interesting presentation in which there was no missing copper T thread. The thread could be visualized through the external os, but because of frequent UTI, an ultrasound was done, and it was seen that one of the horizontal limbs was perforating the bladder, and rest of the IUCD was present in the endometrial cavity. So it was very simple to take it out. They just pulled the thread and patient improved. There was no problem in the post-op period. This is a very unique case again with a very unique presentation. This was a vesico-uterine fistula with menonuria. They did a histography, and on pushing the dye, the bladder and the communication between the bladder and the uterus could be seen. And for this, they had to resort to hysterectomy of the patient, and then fistula repair, and then bladder repair had to be done. This is another very interesting case in which we can see that in the X-ray, IUCD appears to be displaced laterally near the ureter, and in cystoscopy, it was seen that the IUCD was impinging and perforating in the lower left ureter, just proximal to the left uretrovesical junction. So the take-home message is training of health workers and proper selection of client is very important. And it should be done only after determining size and position of the uterus. In any case, when a junior person is inserting, or you are inserting in the first few cases, and you are not sure about the size, or anti-flexion, retroflexion, anti-version, retroversion, or you feel that something is not clear, it is much better to call a senior person at that time. And even the help of ultrasound can be taken. Not in all cases, it should be, this copper T insertion should be done, and properly evaluate whether the patient is having any infection. It is very, very important to tell the patient, counsel the patient about potential complications, danger signals, and explain the need of regular follow-up and self-checkup. If ever the thread is missing, or the thread has shortened or lengthened, then it has to be properly evaluated. In case of missed IUCD, risk of pregnancy should be explained. The patient can still become pregnant even if it is going in the bladder or in the abdomen or anywhere else. So if a woman with IUCD complains of repeated UTI, always look for bladder perforation by IUCD simply by doing an ultrasound. All displaced and migrated IUCD need to be removed regardless of symptoms by multidisciplinary approach. Another thing is that it has been observed that when a junior person is doing IUCD insertion, during the first 10 cases, there have been maximum chances of perforation. And WHO says that the first 50 cases should be done under supervision of a senior, after which the rate of complication has been found to be minimal. So IUCD forms the backbone of the family planning program. And if anything goes amiss in this IUCD, or if there is a complication, it has to be taken very seriously and prompt action needs to be taken. Thank you very much for a patient hearing.
Thank you. Now it's open for question. If anybody wants to ask questions.
Dr. Reena?
Yes, Dr. Joshi, good evening.
Good evening, good evening.
Yes.
Nice cases. We enjoyed all of them. So I have, some queries regarding each case. So we can go one by one. One is, first is your case. How did you decide that it is not a primary?
I'm telling this is primary.
No, how was that made sure? Because of the histopathology you explained?
Because initially we have done a clinical and radiological imaging evaluation of the whole body, and chest X-ray was normal, and we could not find any metastasis in any other areas on MRI of the abdomen. And later on, even after when it was bilateral tumor and we thought it may have come from the lungs, then we got the CT chest done and it was not showing anything post surgery. But after 4 months of starting the chemotherapy, that is tablet etoposide, it was seen in the chest also and the liver also, metastasis later on. But initial evaluation does not show anything anywhere. We also thought it must have come from some other place. It may be metastatic to the ovary, but it was not. And plus CK7 and CK20 was negative. It was not found to be positive, so it was not associated with epithelial origin of the ovarian tumor also. Because most of the case report shows that it is associated with epithelial tumors or germ cell tumor or stromal tumors, or it is always, most of the reports, pure tumor of NCN is very rare.
No, you said she was opened somewhere and open and closed.
Yeah. Somewhere outside private setup, she was opened and they found everything was stuck, bowel, and they could not do anything. They just closed the abdomen without touching anything.
Without even taking a biopsy?
No, without even taking a biopsy. It was not a tertiary care center or something like that. It's some private setup was there.
So whatever it is, I think they can take a biopsy. So that's the message we want to convey, that if somebody is opening and finding it technically difficult, first of all, they should call somebody. They should not open and close. They should take a biopsy. Maybe if you had a diagnosis and when you have to do so much of gut resection, she could have been given neoadjuvant chemotherapy, then followed by probably interval debulking. That could have been adopted for this.
But there is, as far as the chemotherapy is concerned, there are no standard regimen for this particular tumor, or we are not even sure that we should manage it as a lung NCN or a gastroenterine NCN or a ovarian epithelial tumors type. So that remains control. There are reports where they have used 9 cycles of chemotherapy before going on surgery. Of course, they are there. But
particular case, this is the message we should convey to the people who are listening, that if they are opening patient and finding it difficult, at least take a biopsy.
Definitely, I agree. Absolutely, I agree with you.
Lifespan was so short. She could have been given chemotherapy. She could have been probably devoid of this extensive surgery. That is the message I wanted to convey. Because I know these are rare tumors. You don't have standard guidelines. And then coming to the next, screening. Swati.
Good evening, ma'am.
Good evening. So your presentation, of course, it was a work done by a postgraduate, so there are no doubts about it. Definitely, I think I read in the chat box, Dr. Ranjana had a question that why didn't you do HPV? I think that is what most of the literature is now saying in HIV women, because they are going to get HPV infection because of their immunocompromised status. So HPV should be the kind of a test of choice rather than colposcopy. So we all know that pap smear is going to miss. It has got a low sensitivity, but anyway, this was the thesis topic. That is fine. But for the messages that you should get an HPV done, and I have recently also some panel when I read about it, that in some African countries they have started doing screening for this HIV girls if they are sexually active, even at starting from the age of 15 years. So if they are sexually active and they are even 15, 16-year-old, they started screening them. and they've started doing screening frequently, even 6 monthly, they are calling them, because the load of HIV is so high there. So that is why it has to be taken very seriously. Your screening protocols have to be devised based on your own resources and the prevalence of that disease. Otherwise, it was a nice presentation. Thank you for that. And coming to third, that is that hematococcus. Yeah, and a very rare case, obviously learning for all of us. So my only query was in that case that why MRI had not picked up that this is something related to soft tissue imaging. By MRI should have picked up there is something wrong with the bladder. How come? Did you go back to your radiologist and let him review the findings?
Yes, ma'am, we review the findings, but on the each and every MRI, actually these MRI films from the outside. So we don't have a soft copy of these MRI films. In the hard copies, we review the all films, but there was no communication seen in these films.
No. So definitely there must have been bladder. That you have found on opening that there's a bladder pathology. So how MRI films have not picked up? My query is only that. Of course, the management has to be the same, what you have said. But because if you get something different when you open the patient, so then this should be told to your radiologist, give them a feedback that there's something they have missed. So probably this was a urological case rather than a gynecological case, bladder divertive. We had no role in this actually. So
yes,
did you tell them to go back and see the MRI films again?
May I ask in between? Sorry, ma'am, I am just interrupting. So even in MRI, whether those stones were visible? Any clue about those things?
Yes, ma'am. In MRI, there is a hypointense area was there. Or when we did the ultrasound.
Where was it? It was in bladder?
Yes, no, ma'am. These are in the cyst.
And the second thing is that if it is a diverticulum, was any symptom of any urinary symptoms of irritation?
No, ma'am, she doesn't have any urinary symptoms. That's why we review the all literature, and we found that almost in 30% cases, they may be asymptomatic.
And abdominal pain was with her for for a short duration, 1 year only.
Yes, ma'am. She had an abdominal pain off and on. It might be because of this, but definitely our pre-op diagnosis was the hematococcus. We correlate all the things with the hematococcus.
And you were started with the history that she sometimes had spotting and cyclical spotting and all these things were there.
Yes, ma'am. That's why my take-home message was this. Actually, history is misleading us in this case. That's why we make a diagnosis very easily. The patient had initially she had a spotting bleeding, and then that's why after that they developed the amenorrhea. It might be a hematococcus, and with the rudimentary horn, that's why there is a collection in the upper part of the vagina. So the history misleading us.
You have to be very, very cautious about this MRKH patients. They get married, they have not had periods, so they want to hide the history from their husbands. And
she hide the history.
Wrong thing. So this has happened quite often with us. Then actually they have never had bleeding. So because there is no uterus, where from they are going to bleed? It's not.
Yes, when retrospectively we analyzed the case, she said that she developed the amenorrhea after the marriage. So it might be she misleading us for the history.
I think it's a misleading history because she said menarche before and then suddenly after laparotomy she says amenorrhea. So history was misleading.
Can I just come in, Amita? Can I just? We talked to the our radiologist and also the surgeons. They said a very small communication may be missed.
I was actually going to tell the same thing.
A 5 millimeter communication could have been missed.
Yes. So it was so small, and that was the reason why stones were developed, because probably the communication was not that good, that it's not draining urine. That's why, because of this stagnancy, only stones were formed. So
because at one time we had thought that probably it was hemi-obstructed vagina, one part of it, which was containing secretions. Okay, but then of course, when we went back, the radiologist said that was unusual for those stones to be there in that cystic structure, because bladder was absolutely clear. So we were not very clear as to what it is. So this
Even it could be, ma'am, some cyst which communicated with the bladder and urine came, and that's why stones were formed later on.
Yeah, that we could understand and place it. But they thought that why is there those shadows in the vagina? Because we were thinking it was obstructed hemivagina. That is what we had thought.
So Manju, another thought came to my mind. I was listening to this, that because she has had a laparotomy earlier, no? That's what you said. So is it that they have damaged the bladder at that area and it's kind of a false diverticulum? Could it be a possibility?
No. Dr. Vijay, they had opened and they could not see anything. They, kind of stopped because it was a virgin abdomen. When we also opened, they could not identify those two rudimentary horns, one was on either side. So they found that big cystic mass inside. So they did not know what it was. They closed and sent her back, saying that there's no uterus. That's what they said.
But there was some surgery done at very young age, I think.
No. About 6 months back. She had it in November and she came to us in March. So November, she was opened up by a gynecologist in Kanpur. And they opened up, they also thought it was probably hematocolpos only, But then because she did not have any cyclical pain, she kept on telling, yahan pain hai, wahan pain hai. So the history was not fitting in.
And bleeding bhi jhoot moot.
वो भी फिर बाद में she clarified when we talked to her बाद में, she said yeah.
And I think the last case, Vicky, was interesting. Obviously, we have read reports about IUCD in the bladder, but my only query was when you were removing it, so it didn't cause any trauma to the urethra?
No, ma'am, the arms folded very nicely. Arms folded very nicely and it came out. In fact, in the video, it was shown very nicely, but my video did not run.
Yeah, it's okay. No, you should actually put it at the end. ये हमेशा यही होता है. बीच में insert.
Ma'am, कल मैंने dry run में देखा भी था. It was running very nicely and I sent it to Shubham also. Video would have made it very clear coming out of the urethra.
अपने desktop से दिखा देना चाहिए था.
अभी दिखा सकती हूँ.
नहीं, अब तो we'll have to take permission.
खत्म हो गया. It's okay.
AOGD. I think that's all. A wonderful presentation. We enjoyed 1 hour academic feast. It's a Pandora box. Every time there are new things coming. जितने साल आगे बढ़ते जाओ, we are aging, but everything is new coming every time. So thank you, judges, for your wise comments. And I will now request our senior members, Dr. Kamal Bakshi, Dr. Swaraj Batra, Dr. Sunita Mittal, and others who would like to say some comments or share their experience on these subjects. If there are none, then I would. Deepti, can I? Just 2 minutes. Just 2 minutes. Okay. I would request Mr. Himanshu to share a screen. Mr. Himanshu, please. Mr. Himanshu will share his screen. And this is, we, the team, MAMC, will close this meeting on a somber note by paying homage to a dear colleague who left us at prime of his life, Dr. Devendra Kumar. Dr. Devendra Kumar was a true Karma Yogi. He was professor in our department of Obs-Gynae MAMC. He was also heading the department of medical education at MAMC. He was formerly faculty at JIPMER, Puducherry. A very compassionate doctor, a very much loved and a passionate teacher, excellent surgeon, and a dear colleague who was always available with a nice warm smile and an ever helping hand. So our tribute to the departed soul, may his soul rest in peace. With this, I will close the meeting. Dipti, with your permission.
Yeah, please.
Yeah, I know we are all going to miss Devinder. And the last poem he had recited was about the heart. It is so still going in my mind. We had a gathering just a week before his demise, and he was reciting a poetry based on heart. It's a paradox. Anyway, you all know that Dr. Asmita has taken over as President AOGD, and she has given me a little homework. I can say it's a homework she gave to me I think a week, 10 days back. We had that unfortunate suicide by Dr. Archana from Rajasthan. So this provoked her to have a AOGD adverse event support cell, so that we are the members are able to help each other in the time of distress. So whether it could be in the form of an advice regarding the management of a patient, or maybe advice regarding how you have to document your things so that she's saved of any legal hassles. Because most of us are trying our best to do good for the patient, but unfortunately quite a number of our colleagues are landing up in such situations of legal hassles, and it's so unfortunate to lose a life. So I spoke to my colleagues. I think Dr. Manju is also here. Asmita and me had a discussion. I spoke to a couple of more people, Dr. Aruna Nigam. And first of all, we wanted to think ourselves that what should be the name given to this group. So we have various thoughts which came to my mind, to Asmita's mind, and Dr. Aruna. So either it can be an AOGD adverse event support cell, or it could be risk management support cell, or we can make it like an AOGD advisory group to help in dealing with complexities and uncertainties in clinical practice / situations, or AOGD advisory group in advising to deal with the complexities, what I said earlier. Or it could be AOGD support group to help in dealing with adverse events simply. We can just make it like this. Or it could be an AOGD advisory group for helping members telephonically in managing adverse events. And last, these are the various options which came to our mind. So we are inviting, suggestions from all our colleagues that how should we go about it? What should be the appropriate name given to it? Should we have a consultation with a legal expert? Should we be incorporating Delhi Medical Association in it? See, suppose I am giving help to some colleague of mine. So tomorrow day, it should not be that the person who is giving help is only got into that legal hassle. That is an apprehension of some of the colleagues. And basically, our objective is opinion on clinical dilemmas in emergency situation. We want to help. So whatever expertise the senior members are there we have got a large association. So with their experience, they can help the junior colleagues or people who have just started their practice, or even maybe 10, 20 years of practice, you do get into difficult situations. So we are inviting suggestions from all our esteemed members, and we would appreciate that if it is given to us within 1 to 2 weeks by mail to AOGD. You can mail it to Dr. Asmita, and then we'll sit together and see how we have to work on it and carry it forward. Asmita, you have to say anything?
Vijay?
Yes, ma'am.
It's a very good suggestion. But what I would say is that we should incorporate a legal, a police person, a lawyer, see all of them. Because when a person, just like as Archana was with the people surrounded, as they say, which is a small place, where they had a police and everybody, if we have that, then that the emergency can help. And as you very rightly said, if you are helping, we do not want any member to get into the problem. So the group that we are forming, that is one. Secondly, see, my video was not, this one was not working on whatever said. I want to congratulate Lady Harding for a very lovely discussion and lovely case presentation. And I tell you, even 1 hour felt like as if it was only 5 minutes. Means interesting presentation. My congratulations to all of you. Thank you for the time.
Thank you, ma'am. Asmita?
Yeah, Dr. Mittal, would you like to make any comments?
Surely, I would like to endorse what Dr. Bakshi has said. It was a very, very interesting presentation. In fact, cases were so rare and interesting, and they were so well documented and presented. That was the beauty of it. And I appreciate your suggestion of making a support group in whatever unfortunate events have occurred with Dr. Archana and others. We must have a support group mutually so that you know that there is somebody you can fall back on. I think AOGD can take a good initiative in this.
Thank you, ma'am, for your comments. And with this, I will call this meeting to a closure. Thank you very much for attending from all of us.
Thank you, Dipti.
Thank you.
Smita. Thank you, Dr. Dipti.
Thank you. Thank you, everyone.
Thank you all.
Thank you, everyone, for making me a part. Thank you.
Thank you. Excellent presentation.